A lot of people in this room will go on to become parents. Some of you already are parents. It's something that we think about a lot growing up, starting our family, but less people think about the actual journey to becoming parents. So pregnancy is normally a pretty uncomplicated time. People are often healthy, but there are a few things that can throw a wrench in that, and one of those things is called gestational diabetes. It's a serious but manageable condition that can arise during pregnancy. And I know a lot of you are probably thinking, oh, this has not been interesting. This does not pertain to me. I'm not a parent. I don't know if I want to be one later. But statistically, according to the March of Dimes, about 85% of women will go on to become parents by the time they're 40, and about 60% of men will. So this is something that a lot of you guys, more than half, will more than likely have to think about in your lifetime. Hi, I'm Hannah. I'm an LMCPM, so I'm a midwife here in Coeur d'Alene, Idaho. I have ran and interpreted a lot of the labs that we do for this condition, and I have talks with families about this on a weekly basis. I think it's something really interesting. So I try and keep up on new studies and always try and stay informed about this subject, and I'm really excited to talk to you about it today. I think a good place to start would be to talk about what actually is gestational diabetes. So essentially, gestational diabetes, or GDM, is a type of glucose intolerance that can arise during pregnancy. During pregnancy, our body just has an increased need for glucose because it's one of those building blocks for growing a new human. Often our pancreas can make more insulin and kind of keep up with that increased need, but sometimes we don't. During pregnancy, the placenta produces hormones like cortisol and progesterone, which are really, really wonderful for supporting a pregnancy, but can be hard on the body because they interfere with how insulin works, causing insulin resistance. Normally the pancreas can make that extra insulin to keep up with it, but during gestational diabetes, it has a hard time doing that. And that's when we start to see that rise in blood glucose levels, and that's when we start to see problems. When left unmanaged or untreated, we see a lot of pretty significant risks. Things like a higher risk for macrosomia, which is a baby that's a little bit bigger than they normally would be, sometimes particularly in the chest area. Birth complications like a C-section or shoulder dystocia, which is an emergency that can arise during delivery. The rate of stillbirth increases. The rate of preeclampsia, which is another serious condition, increases. And actually the risk for type 2 diabetes for both mother and baby also increase, which is wild and a rough one. Some of those things can feel really, really scary, but there's routine screenings that can be offered by your care provider that will enable you to catch this early and treat it, and then we have really great outcomes. The standard of care for a long time was a 50-gram oral glucose tolerance test. So you come in fasting, somebody would drink 50 grams of oral glucose, and then we would draw labs about 1 hour later. If their blood glucose levels were 135 or higher, then you'd be sent on for further testing to diagnose for GDM. As new studies come out, we found that a 75-gram load of glucose is actually more effective, and we can diagnose it with just one set of labs. So we would draw after the drink at 1 hour and 2 hours. At that point, if we look at labs and we can see that your body's having a really hard time leveling out that blood glucose after that sugar load, then we can diagnose you with gestational diabetes and go from there. The last way that we can diagnose it is just to keep a log at home. You can monitor your blood glucose regularly at home with a glucometer and write down the things you eat, and that gives us a lot of really good data to look at. And from there, we can either diagnose or not diagnose gestational diabetes from there. So what happens when somebody undergoes routine screening and they're in that 8% of people per the CDC that has gestational diabetes? Well, there's a lot of really good ways to manage this condition. The first line of defense is just a diet shift. Lily Nichols, in her book, Real Food for Gestational Diabetes, kind of essentially talks about it as a carbohydrate intolerance during pregnancy, and that is really what it is. So oftentimes it's just eliminating or reducing carbs in the diet really solves the problem. Things like exercise can help, but that is really our first line of defense, and it often works really, really fabulously. As we move on to more pharmacologic options, metformin, which is per the National Library of Medicine, the most used drug for gestational diabetes, also works really, really well, and we see it fairly often. It works by decreasing the amount of glucose that's absorbed during digestion. And then the last thing that we would choose would be insulin. You would think that insulin would be the first thing you would jump to, but it's really cost prohibitive, it's hard to store, it's a lot of labs, and it's a lot of monitoring. So when something as simple as a diet shift fixes the problem, it's not often that we see insulin used during gestational diabetes, which is really nice. So a lot of those things can feel like a lot of work, a lot of things to do, but early diagnosis and treatment and regular monitoring make this still a really treatable, really manageable condition. When managed, the prognosis is excellent, both short-term and long-term. Normal birth weight's likely, C-section is unlikely, shoulder dystocia is unlikely, the risk for preeclampsia or type 2 diabetes for mom or baby go down significantly. So it reduces a lot of risks in the end. A lot of those risks can feel really scary, but I want to drive home that when we catch this condition early and we treat it, the prognosis is excellent and the pregnancy can kind of continue on without a hitch pretty often. So it all boils down to a couple of main points: that gestational diabetes is a serious but manageable condition. By undergoing routine screening like the oral glucose tolerance test or monitoring at home, it's something that we can catch early and we can treat with things like a diet shift or pharmacologic options like metformin or insulin. And when it's treated, we significantly reduce the risks that we see for the remainder of your pregnancy and beyond. So there's so much that we can do to stay healthy. So I want to kind of leave you guys on the note that gestational diabetes does not have to define a pregnancy. It can just be one small blip in an otherwise really exciting and healthy journey.